Hi everyone, my name is Briana Costello. I'm a general and interventional cardiologist here at the Texas Heart Institute Center for Cardiovascular Care. I'm super happy to be here at the 12th Annual Women's Heart and Vascular Symposium. I can't believe it's 12 years. Dr. Coulter has done such a great job the last 11 years, and I'm looking forward to the rest of the presentations today. So my topic today is coronary artery disease guidelines. This is a big, huge topic. So I'm going to focus in a little bit on more of what we see often as providers and clinicians, stable ischemic heart disease, but we'll kind of touch base on a few other topics here and there going off the guidelines. My objectives today will really just to be defining what is coronary artery disease and what is the spectrum of disease that we see. Understand the approach to management of stable coronary artery disease with both left main and multi-vessel CAD. Number 3, understand options for therapy for stable CAD. And number 4, understand outcomes for patients that have stable coronary artery disease. These are the two major guideline publications that I will be referencing. You could see on the top left here, this is the 2021 guideline for coronary artery revascularization from JACC and AHA. And there's also a 2012 guideline for stable ischemic heart disease, a little bit older, but still very pertinent to this discussion. So let's just start. What are the facts about coronary artery disease? So approximately 1 in 3 adults has some form of cardiovascular disease, which is a striking number. Look around the room. You might see someone who has this problem and doesn't quite know it, but the facts are 1 in 3. Greater than 17 million of patients have coronary artery disease to some degree. That's huge, 17 million in the US. And then, of course, as I'm sure we know, or most of us know, heart disease is the #1 killer of both men and women. Prevention measures and early detection have really brought to light early coronary artery disease diagnoses and provided us the opportunity to intervene early and make a big difference later on in our patients' lives. And then one of our favorite topics here to discuss is lifestyle and how our lifestyle really portends what is going to happen to us later in life. So what we do makes a big difference. Coronary artery disease, it's like this here, it's a spectrum. So, wavelengths of light. We have gamma rays all the way to radio waves, and then I just picked the visible light spectrum of what we see in coronary disease, and what we can identify is a small part of that disease process. So there are many flavors and many colors of coronary artery disease that we'll get into here. So what types of coronary artery disease might you encounter? So non-obstructive coronary disease, your patient who has plaque but has not quite become symptomatic. That might be picked up on non-invasive testing such as CAT scans or calcium scores. There's, again, the most common one that we talk about, which is obstructive disease, and that is when the coronary artery plaque has been progressing enough where it's become either an issue or identified as more than 70% diameter reduction in the coronary artery. Total occlusions, which sometimes we encounter, and patients actually are relatively well compensated, but an artery that's totally occluded. And then microvascular dysfunction, which over the last 5 to 10 years has really become a big focus for us cardiologists and physiologists, really, to figure out what is going on in the microvasculature that can cause symptoms or cause abnormal flow in our coronary trees. This illustration here on the right is from Journal of the American College of Cardiology, and this particular publication talks about normal and abnormal structure and function of the coronary micro and macro circulation. So you see on the left the epicardial arteries, which we encounter when we're doing caths or coronary angiograms, and what we see or hope to see are widely patent arteries without plaque. And then it goes all the way to the right down to the capillary level, which are tiny and really are in charge of a lot of the resistance that the blood meets when it flows down through the vasculature with every heartbeat. You can see here the from going from left to right, you can see that 30% of the prearterioles and then 60% of the arterioles are what give us the resistance to blood flow. This makes a huge difference in patients' symptoms. We have recently found if that resistance is abnormal or higher. This, again, is just touching on the abnormal structure and function of the arteries in our heart. So you see structure on top and function on the bottom. Structure on that top left, you see there's atheroma or atherosclerosis starting. And then you can see this disease process isn't only affecting the epicardial or main arteries, main large vessels of the heart, but it also affects the capillaries distally. The function, of course, this holds true for the function too, as the vessels become stenotic or there is microvascular changes distally, the resistance increases, and this is when you can really get microvascular dysfunction and symptoms. A quick note on calcium scoring as it relates to coronary artery disease, because this is a very, very hot testing tool that we use for patients to identify what, or risk stratify. Do you have coronary disease? Are you asymptomatic, but you've already started the ball rolling and putting plaque in your arteries? This test is non-invasive. It's a plain CAT scan. It can be done at many facilities, and it takes less than a minute to perform, and it can give you, the provider or the patient, a lot of information about what is your patient's risk. There are many patients nowadays that are very hesitant to be on medicines of any sort, despite having maybe a family history of coronary disease or a family history of early heart disease or heart attack. This test can really kind of convince patients that, changing their diet or being healthier or getting on a statin or a cholesterol-lowering drug is important. Once you're identified as having calcium, you have, quote unquote, some plaque in your arteries, because calcium in the arteries of the heart, the calcium where it has gone to when it goes to the heart arteries is areas of plaque. So that calcified area is a site for plaque. So as the calcium scores go higher, a perfect score is 0. Everyone wants a 0. But as they increase, that portends a higher risk for major adverse cardiac events long term. All right, so other types of coronary artery disease, as I said, there's lots of flavors. I want to just touch on one of the big topics in coronary disease that gets a lot of credit for what we do as interventionalists is acute myocardial infarction. So when someone comes in with having a heart attack, what does the artery look like? That's A up there, figure A, and that's just, it looks like the blood stops. It's just chopped off. And then after, if someone comes in with a heart attack and they get it fixed with a stent, B is what we hope it looks like at the end, widely open and patent, so we can give that muscle blood flow and prevent muscle damage. That bottom picture there is an illustration of really multi-vessel disease, which is going to be most of the topic of what I continue with moving forward. So we'll talk a lot about stable asymptomatic and symptomatic coronary disease. All right, so stable ischemic coronary disease. This comes from that guideline that I mentioned earlier, the revascularization guidelines of 2022. And you can see it's a very busy slide, and I'm going to break this down into parts and talk about what we do and why. So SIHD, stable ischemic heart disease, up at the top. Let's start with a very simple part of this diagram, and that is, does your patient have stable ischemic heart disease? However, meaning they're not coming in with a heart attack. However, they have chest pain or angina and they're on good medical therapy. You've titrated their meds, you've put them on as much blood pressure and beta blocker and anti-anginal drugs possible, but do they still have pain? And if the answer is yes, then revascularization is a class 1 indication. And you see on the top left, these are indications to improve symptoms. That's important because we've had a really hard time with trials to prove that stents improve mortality, but symptoms certainly. So stable ischemic CAD in a patient who has no refractory chest pain, meaning they actually don't have much chest pain. So that's the right side here. So no, you don't have refractory chest pain, but do you have left main artery disease? So the major tree trunk that comes off on the left, does it have a problem? And if the answer is yes, and it's a significant stenosis that you think by whatever testing your interventional friend does, if it's an IVUS or if it's a stress test result that you're following and you see a left main disease on cath, what complexity is it? Is it high complexity? Is it a distal left main stenosis that's going to turn into a complicated PCI? If the answer is yes, and the patient is suitable for a bypass surgery, meaning their other comorbidities would allow for bypass surgery, and syntax score is calculated, and you decide with your vascular surgeon, your cardiothoracic surgeon, that it's a good idea, then bypass surgery is a class 1 indication. If they don't seem like they're suitable for bypass surgery, then medical therapy might be your answer, or PCI, meaning a stent instead of bypass. Now, if they have a significant left main stenosis, but the complexity is low complexity, it's a proximal left main stenosis that you can get in and put a stent easily without thinking that you're going to have to do a bifurcation, meaning 2 stents, and make it more difficult, then PCI actually gets thrown into the equation, meaning stenting this area with a 2A indication. You'll see that bypass surgery is still a class 1 indication for this disease. So this, all to say that this intervention, meaning surgery or in the 2A indication of doing a PCI of the left main stenosis, this is actually to improve survival. And there are studies that back this up. And the strongest evidence for this in the past really decade to support bypass surgery in a patient with left ventricular dysfunction and CAD has been stitch. So let's go down this little, this cascade here on this picture where left main disease, no, multivessel CAD that may or may not be suitable for bypass surgery or CABG. If the answer is no, then medical therapy if they don't have left main. But if they have left main, we know that the VA held they did a trial with many patients, and patients with left main, so not this side of our diagram, patients with left main who were left untreated actually had higher mortality. So important to remember, left main is a different disease than what we're about to start talking on this slide. So left main disease should address it. If not left main disease, here in this diagram, no, but has multivessel disease, maybe has 3-vessel disease, and is suitable for bypass surgery, then we have to think about, okay, well, what is their otherwise LV function or ejection fraction? If it is less than or equal to 50, then they're suitable for a bypass, yes, then we should probably discuss that with the patient. A lot of patients say, well, why can't you just stent me? There's reasons for this. PCI has, again, unfortunately to my interventional colleagues and myself, has been hard to prove is better than bypass for this disease. So for example, stitch, like I mentioned earlier, the stitch trial, which had randomized patients with an EF of less than or equal to 35 to bypass versus medical therapy alone, initially didn't demonstrate a survival benefit, meaning mortality wasn't changed, but at 10 years, there was a survival benefit for those patients who had bypass surgery. So multivessel disease at 10 years was shown to be better treated with a bypass approach. Again, I'm just going to keep harping, that VA trial that I discussed, left main disease had a 70% mortality benefit at 42 months. And then, again, back to this diagram, ischemic cardiomyopathy, we'll start there again. So if they don't have a cardiomyopathy, they have 3-vessel disease, but their ejection fraction is 55%, then you can consider bypass or PCI. Again, symptom management is paramount usually when we talk to these patients in the office, and really kind of prying to make sure that their symptoms are well controlled if you're not going to go down the bypass route. There is some data more recently for non-complex left main PCI, meaning that easy maybe ostial left main or ostial to mid left main disease that can be better treated or equally as treated with outcomes to bypass. This multivessel disease with a preserved ejection fraction here on the bottom right put a lot of our surgical friends in a tizzy because this used to be a higher indication, multivessel disease, to treat with bypass. But again, there have been multiple trials that have proven that guideline-directed medical therapy works for many patients and their disease can be stabilized. These older trials, such as the STITCH trial, were performed when we didn't have as many good medical therapy options. Statins weren't widely used during this trial, and anti-anginal therapies weren't quite as aggressively used. So we've come a long way with medical therapy. Again, so left main disease, if you don't have it and you have multivessel CAD that may or may not be suitable for bypass, I will go deep into a guideline-directed medical therapy trance right now with you guys and kind of talk about what we mean when we say this. So what is guideline-directed medical therapy? It is diet, it's weight loss, it's activity, getting patients to get up and move more than 150 minutes a week. It's smoking cessation. This is huge. If patients are smoking, it is the #1 modifiable risk factor for vascular disease to progress. Antiplatelets, we'll get into those, cholesterol medicines, blood pressure control, glycemic control. So a little tidbit on each of these: diet, weight loss, regular physical activity. It's clear, and it's been for many years, that Mediterranean diet is the diet that we should be encouraging patients to at least mimic at home. BMIs of 25 or lower are quote-unquote normal, and we should really kind of aim for this, a BMI of 25. BMIs are a little tricky, especially in people who might be very muscular, but as a general rule, a BMI of 25 is normal if you can get there or lower. And then activity is paramount. 150 minutes or more activity per week can decrease your risk of stroke and heart attack and death, okay? So this is a no-brainer, even if it's walking. So get up, walk your dog, go for a brisk jog or a brisk walk, or go for a light jog. Whatever you can do to get active is good for your heart and good for your long-term, your lifespan, really. This is from the American Heart Association here. You can see if you're doing more intense physical activity, you need to do a little bit less, but the more you can get, the better. Smoking cessation, I had to just put this picture. This is from the ESC Congress back in 2013, but I had never seen it, and I thought it was very interesting. This group, James K. Min and his partners, illustrated that smokers, if they quit, can actually decrease their risk from death, heart attack, and unstable angina almost or to the degree of a non-smoker. You see that green line here is never smoked, and then follow up over 3 years, and then quit smoking here at time 0. Those lines meet over at 3 years. The full article was, I couldn't access it. I would have loved to dive deep into this, but I just want you to know that you can encourage your patients. Look, yes, you may have been smoking for 10 years, 20 years, but you can decrease your risk. That's the general theme. You can decrease your risk back to a much lower one if you quit smoking. So whatever you can do with smoking cessation therapy is paramount for your patients long term. This is a hot topic that Eduardo Hernandez touched on, I think, last year or the year before, but aspirin therapy. So 81 milligrams of aspirin a day, especially in patients who have established coronary disease may or may not have had a heart attack before, or stroke certainly, is part of our guideline-directed medical therapy. It's a controversy because bleeding risk is very important to assess. And in Europe, the ESC guidelines would suggest that even by calcium score, if you have a calcium score more than 100, they will recommend 81 milligrams of aspirin a day if you're acceptable bleeding risk. If you've had a prior stent or bypass surgery, again, P2Y12 or aspirin therapy lifelong until indefinitely, unless there's a reason that you can't tolerate it anymore, is generally what we push. But it's a patient-centered decision. I think one of the most common things I see in the office is patients who are on even just a baby aspirin and they have tons of bruises, or they have gastritis and they've tried a PPI to decrease the gastritis issue and it just hasn't worked, and they're 10 years out from a PCI. So you have to really think, is aspirin needed? How old are they? Are they benefiting? What is their long-term benefit from staying on it if they're 80 or 85? Okay, cholesterol. Cholesterol lowering therapy. I love this illustration here this is another illustration from Jack, just showing all the very cool ways that we can modify cholesterol nowadays. And even when I was, a med student, I thought that statins were our only option, and patients really just needed statins. But it's true, in clinical practice, many patients can't tolerate statins for whatever reason it might be, and we have options now, and cholesterol lowering therapy is paramount. The new cholesterol guidelines in someone with high risk for recurrent heart vascular events, or at risk for vascular events, high risk, we really are targeting an LDL of 55 or lower. And that is a big change. Historically, we haven't targeted that goal, and we've been getting there. Maybe you need a statin plus something else, but it's something we need to focus on and we need to really hone in on with patients so they know what to expect. What are we working towards? I love this illustration. This is cumulative incidence of MACE stratified by statin treatment and coronary artery calcium severity. Okay, this is back from 2018. So patients who might not have had a heart attack or stroke or heart failure or whatever, but they have a calcium score that you got with them, and you want to discuss why it's important if their calcium score is 100 or 400 or 2,000, why you think that cholesterol therapy is necessary. And this goes, calcium score of 0 is up in the top left. Top right is calcium score of 100, 0 to 100, and then 100 to 400, and then more than 400. And the blue line is patients not treated with statins. So the red line, so you can see the point of this is, if you're treated with statins, red line, versus not treated with statins, blue line, your lines are significantly divergent, meaning the patients who have calcium or coronary disease and do take statins have very significant lowering of their risk of having major adverse cardiac events. So statin therapy works. Again, if patients can't tolerate it, talk about a different option, but lowering the cholesterol is necessary. All right, I like this little image over here. So patients, guideline-directed medical therapy for patients who have coronary disease. What is our goal? And for patients who have chest pain, the goal is, how do we decrease the consumption and supply oxygen discordance that's happening to their muscle? So you want to decrease demand and increase supply of blood to the heart muscle to decrease chest pain, okay? And anti-anginals, there are many, again, flavors of anti-anginals. The most common ones and the most simple ones to start on patients is beta blockers, calcium channel blockers, Imdor or long-acting nitrates, ranolazine. We have lots of options. So this is just to kind of underscore that we have options for patients who maybe they do have some diffuse coronary disease, but we can make them feel better, and there's many ways to try to do that. Blood pressure control is another big way to decrease demand and therefore increase supply. All right, glycemic control. I know we have topics on this today, and this is a very fun, long, it could be an hour of talking why glycemic control is important for your heart and your heart health. So I'm going to kind of skip through this one. And then one of my favorite things to talk about now is sleep apnea. And if I scrolled back to one of my first slides, the American Heart Association have Life's Essential 8. And those are the 8 things that we as clinicians need to focus on to improve heart health for our patients. And sleep apnea is one of those now. I've been kind of putting a lot of illustrations from Jack, and I like this one a lot. So what are the possible risk factors for sleep apnea and the downstream consequences. So obesity is a huge one. Upper airway is another one, but obesity is a modifiable one. And long-term sleep apnea, if untreated, it increases risk for heart attack, heart failure, stroke, memory loss. And patients don't often know this. So when I have this conversation with patients about why I care about their sleep study that I want to order, they're kind of surprised and they kind of jump on the bandwagon like, okay, you're right. I guess I just thought the sleep apnea was, a different topic, didn't relate to my organs, and it was just about my oxygen when I was sleeping. But when you put it into the big picture, a lot of patients, they can understand why it's important to treat. So sleep apnea is a part of our American Heart Association Life's Essential 8, and I'm a huge proponent of screening almost every patient, especially if they're a snorer or if they're overweight, and it's easy to do nowadays. A quick note that I would be remiss if I didn't mention, there is good data for our patients that have that stable ischemic heart disease that suggests deferring revascularization, meaning PCI for many patients, or stenting. It doesn't change the outcomes in the relative close future. So guideline-directed medical therapy is not only recommended, it is essential, if possible, prior to making a decision about what your patient needs. So catch your breath, take your time. All of my prior mentors, it's always good to have a thoughtful pause and talk to your patient. Slapping a stent in someone, it sounds very simple, but a lot of times we aren't thinking about what other issues do they have. We're putting you on antiplatelet medicine, meaning quote unquote blood thinners, as many patients call it, after you get a stent. What is their life like? What do they do for a living? Do they have AFib? Is this going to be a complication because you have to have them now on 2 drugs that are going to make their blood thinner? So catch your breath and think about it. It's often good to, have a few conversations with a patient before making a decision. And this is from that guideline, the 2021 guideline. Again, it's just super, it seems obvious, but it's important that they emphasize the patient-centered approach and the heart team discussion, especially in those tricky scenarios where a patient might benefit most from bypass, but they're having issues kind of coming to terms with that, or maybe they're a sicker patient and you can't decide what the best option is, and maybe it is really guideline-directed medical therapy only. So shared decision-making is important. You have to think about the patient's overall health and their social determinants of health. You have to think about what is the risk-benefit to doing your procedure, whether it's bypass or stenting. It's always good to phone a friend or have that heart team discussion if you're not sure and it's not obvious. All right, well, thank you. Again, I hope this presentation taught everyone a little bit of something, if it's not one thing, a few things. I am very grateful to all of my partners here that you see at the Texas Heart Institute Center for Cardiovascular Care. Wouldn't be able to do it without them. And I hope you guys enjoy the rest of this, and thank you for having me.